The new and supposedly improved version of the COVID vaccine has finally arrived. The omicron-based bivalent vaccine was advertised to provide greater protection than the old vaccines, but a study published in New England Journal of Medicine this month found that the latest iteration might not be that much of an upgrade.
Writer David Zweig highlighted the finding, tweeting, "Surprising data from the bivalent booster trial that has received little notice. The bivalent booster conferred no benefit over the old booster for preventing infection. Sample is underpowered, and this is an exploratory finding, but it certainly raises some questions." Here to suss out these questions is Zweig himself. Welcome, David. Great to have you back.
Thanks for having me back.
Yeah, so this is, I think, a really important discussion. What was your takeaway from this new data? And are we just looking at, so my understanding is this study, while limited and, we don't want to draw too many conclusions from anything at this point, but it is looking at basically how well the bivalent booster, which is supposedly is going to offer additional, on paper, offering additional protection against Omicron, because it's specifically, part of it is to target the actual variant we have now. But according to this data, this vaccine was doing no better at preventing cases. Is that correct?
Correct. So the trial data was for a bivalent, including for BA.1. The bivalent that's here in the States is for BA.4/5, where we don't even have these data. So we're sort of like multiple levels removed. But in the absence of any clinical data for the bivalent that's introduced in America, we can look to this and at least try to extrapolate. And correct, this was not the primary endpoint. So it's very what they call like underpowered. There are not enough people. But this is all we got. So of the limited actual clinical data on infection, on preventing infection, there was no benefit.
And of course, the original vaccine over time, was eventually getting to a place where it was hard to discern any benefit as well in terms of cases, in terms of infection. Now, the theory is still that it might help you, or I think it does help you, especially for older populations, for people who are at risk of severe disease. It's preventing severe disease. Maybe, for those who are not particularly at risk, maybe the vaccine causes you to get less sick. I'm not sure we know that for absolute certain, but that is a theory. There's maybe some evidence to support it. So could the case be here that while, like the old vaccine, it's really doing nothing to stop you from catching COVID, if you do catch Omicron or the new variant, you will maybe not be as sick if you've got this vaccine?
Well, we just don't know. We don't have the data. So that doesn't mean it's unreasonable in all circumstances necessarily to use antibodies as a proxy for a clinical outcome. However, the authorities should be very upfront about what we know and what we don't know. And I think for the average person in the public, they hear, oh, the CDC has approved this thing, and they recommend a full rollout for everyone 12 and up. Well, let's do it. The average person is not following this stuff closely. Again, I just want to emphasize, this doesn't mean that it's dangerous necessarily. It means we don't know. We are using antibody production as a proxy to indicate to us what might happen in a clinical context, meaning like in the real world. How much does the antibody boost actually translate to how much does that translate to actual outcomes with preventing infection, or more importantly, preventing severe disease or death? And the answer is we don't know. And this small amount of data from this trial, which was an exploratory finding, they called it, showed that the new bivalent for BA.1, that bivalent vaccine, did not perform any better than the original booster. And to me, I think this raises a lot of questions regarding how the vaccine, when it's not that it necessarily shouldn't be available for particularly vulnerable people who need it, but there's not clear messaging, or I think perhaps incorrect messaging, in saying just roll it out to everyone. The director of the CDC, Rochelle Walensky, said, we want to simplify everything. But from all the infectious disease specialists I speak to, and quite honestly, just being a citizen, when you talk to, when you go to your doctor, that's kind of the opposite of how a lot of medicine typically is practiced, which is not just, let's do everything for everyone. We're all different. There are different buckets of people, and the associated harms and associated benefits from the vaccine versus COVID vary significantly in different populations. But nevertheless, the recommendations from the CDC don't acknowledge that. And that's particularly worrisome, I think, when we don't even have the clinical data yet to know what we're getting.
Yeah, this new data comes just as the Centers for Disease Control and Prevention announced its plans to recommend the new boosters to 5 to 11-year-old children by mid-October. I want to ask you about that, but I just had a follow-up to clarify, because it was my understanding that the boosters' efficacy when it was released was better back in the fall of 2001, because it was more correlated with the strains, 2021, because of the strains that were happening at the time. And so if the new boosters, and that they have lost efficacy over time as we've engaged with new strains. So if the new boosters are as effective as the boosters were initially back in 2021, isn't that a good thing? Isn't that an improvement on the mean that we've seen over the course of the past year when we haven't had any new vaccines or boosters, but we have had new kinds of variants?
I'm not entirely sure what you're asking, but what these data showed.
Well, what you're describing here, right, is the idea that we are measuring whether or not these new vaccines are effective based on how many antibodies they provoke, and that doesn't necessarily pan out in terms of whether or not people are infected at lower rates or whether they transmit COVID at lower rates. But you're measuring against its efficacy against the original efficacy of the vaccines, right? Saying it's just as effective as the last ones, it's not an improvement. But didn't we see a tapering off of efficacy? And so that if this is as effective as the initial vaccines were back in 2021, that actually is an improvement on how the vaccines and boosters we've been using over the intervening year have actually performed.
Right. Okay. Now I understand what you're saying. I think just to kind of pull the lens back a little bit, again, I think the important lesson that I draw from this, and I, before I came on to speak with you both, and just as a kind of general matter of course for me each day, I talked about this with a number of immunologists and infectious disease specialists. And again, the real thing to focus on, I think, is that we are using one thing as a proxy to represent something else. And it's not necessarily unreasonable to do that. However, this small amount of data we have show that there's not necessarily an improvement with this new bivalent versus the other one. And where this matters, I think, is in the CDC's recommendations, because then you're not up to date anymore unless you get the latest and greatest version. So this creates a situation where you're then compelling people who may not be at particularly high risk when you think about younger populations. And what I've been focused on for more than a year now, particularly are young males who are at increased risk of myocarditis. So if they're at college and the colleges are now enforcing a mandate for them to be, quote, up to date, which would include yet again another booster, we don't know how much benefit they're getting in an actual real world setting. We don't know if that translates to what amount of severe disease is this actually preventing, particularly in people who had prior infection. We don't know the answer to that. That doesn't mean the product shouldn't be available to those who need it, but I think there's a lacking of nuance in the recommendations from the CDC, and then that gets translated down into a mandate at in institutions or for kids with athletics. I'm glad you had me on, because they just published something in the Lancet on Wednesday showing more myocarditis data, and it doesn't look good. It's not
Yeah,
transient.
I totally take the point about young men. I'm just trying to get clarity on what this particular study, how that bears on this. Do you know what I'm saying? Because having a more targeted, narrow policy is relevant across the board, regardless if we're talking about a new vaccine or old vaccine. I'm just trying to have some clarity, and you've been so helpful with that, about what is new, in fact, about this new vaccine. Thank you so much for joining us, David.
Thanks for having me.
We'll have more Rising for you right after this.